real life.
Okay. So, good evening, postgraduates, and my namaskar to all the mentors. Welcome to this 112th episode of All India Online Postgraduate Teaching Initiative from AIS ARC. We are very fortunate to have Dr. Unni Nair, a busy vitreoretinal surgeon and a very lucid speaker to speak for you on BSCANs. Also, we have other moderators, senior discussants like dear friend of mine, Dr. Bhushan Kare, Dr. Abhijat Chaturvedi, and Monish Saxena. So, without much ado, can I request my ARC North coordinator for today's program, Dr. Tikku Bali, to carry forward the proceedings?
Thank you, Dr. Prashant, and a very warm welcome to everyone who's joined us this evening. Our topic today is one that every ophthalmologist, especially our postgraduates, must master, that is B-scan ultrasound. So, whether it's an opaque media or an uncertain diagnosis, a well interpreted and a well done B scan holds the key to solving the diagnostic puzzle. But it is truly one of the most useful yet the most underutilized tool in ophthalmology, I would say. So, today's session, Let's Learn to Interpret, is all about bridging the gap between performing a B scan and truly understanding and interpreting it so that we can confidently, correctly, and meaningfully apply it to our clinical practice. So, to do that for us, we have with us, as Dr. Prashant has already introduced, Dr. Unni Nair, a prolific VR surgeon who is not only an expert surgeon but also a brilliant teacher who makes complex concepts very simple. So, he is going to be unraveling the mysteries of B scan for us this evening. And Dr. Uni is known for his very clear, structured, teachings. So looking forward to your talk, Dr. Uni Nair, and thank you so much for sparing time and being with us. Joining Dr. Nair, we have an excellent panel of discussants who will also add their own perspectives and clinical pearls at the end of the talk. So we have Dr. Manish Saxena, who's a vitreoretina surgeon at Sri Aurobindo Nethralaya, Raipur. We have Dr. Bhushan Khare, who's a vitreoretina surgeon at the Khare's Eye Institute, Pune, and Dr. Abhijat Chaturvedi, who's a consultant vitreoretina and phacosurgeon and also the assistant director of the Akshi Eye Care Center at Kanpur. So thank you all for your presence here this evening. And with that, let's dive into the topic. Over to you, Dr. Uni, for your talk on B-scan ultrasound.
Thank you
And
so much for the introduction. Yeah.
before we begin, I'd request all the postgraduates to please keep their questions coming in. We have a chat box and you can also post on Facebook. So please keep your questions coming in. It's a good time to solve all your queries. Over to you, Dr. Nair.
Thank you so much. And on the occasion of the World Sight Day, it's an honor to be presenting today on BSCAN. And just before I share the presentation, BSCAN is only as complicated as you can make it be. You can make it amazingly complicated by overthinking and missing findings, but brilliantly simple if you know a few points click in your mind. Let's see if we can unravel them. I'm not sure we'll see if we can unravel them. Okay. So just get this out of the way. So we're just talking about ophthalmic ultrasonography, which we call B-scan, and it's a second nature to us to order B-scans and not order ultrasonography. Okay, so just a quick about the components of the equipment. This is more about interpretation. So I'm just going to skip. There's an electrical power source which causes a crystal to vibrate, a transducer to vibrate. It produces a signal. The signal goes inside the eye. And like any signal or energy going inside the tissue, it is modified and it comes out. It is reflected, it comes out, and it is reconverted into something that we can interpret, and that is the display system. The basic is just this. These are acoustic waves. Anything more than 20 kilohertz is supposed to be the definition of ultrasound beyond sound. And our ophthalmic ultrasounds have a variety between 8 to 20 megahertz, and they can go up to 50 megahertz for more focal or high definition anterior segment imaging. So the very basics of ultrasonography, the B in B-scan is brightness. We'll come to it later. The A is amplitude. The return sound is called an echo. Like anywhere in the world, it's called an echo. what we see is a modified echo. What goes in is not exactly what comes out. The sound is modified. The speed, the time, and the nature of the modification is what is interpreted as a dot. The intensity of the dot and the timing of the dot all put together is the image you see. So the image you see is a variety of black, white, and gray, depending on the intensity. And all these things come together, and that's how you interpret what you see uh, inside the eye. So how does the basic thing work? There is, as I said, the echo is, or the light is modified. How is it modified? By the two principles of impedance. Impedance is a resistance to transmit light because of the nature of the tissue. A denser tissue slows down the light. A more hollow tissue, the sound, I mean, sorry, very sound. And the less dense tissue, the sound goes faster. And the most important thing we have to realize is that an echo is like when you have a light reflected, there has to be a surface. Like that, an echo is because there is an interface when you have two different acoustic natures or acoustic nature of two different tissue. And because of the difference, a light is reflected or the sound is reflected. Sorry, I'm going to make this mistake often, but the sound is reflected or the sound is transmitted inside. When the reflecting or returning echo is displayed as a vertical line or what we call a spike. Like you have any spike, the spike has got a height and the spike has got a distance from the baseline. So the height tells you how strong the spike is or how good the echo is, and the distance from um, the point tells you what is the speed of the transmit and when has it come back. So it tells you time and intensity. Now, what a BSCAN does, it transfers into a two-dimensional display. The spike or the amplitude is converted to a dot. The intensity of the dot depends on how strong the returning echo is. And the position of the dot is a reflection of when the dot came back. And you can imagine a dot that has come back faster or earlier is like in the mid-vitreous cavity, something that has taken more time. It is probably gone to the retina and reflected back. And that is when you see a dot in the center, you know the dot is from something that is in the middle of the vitreous cavity. And because of the nature, if something is returned slower, it is co-localized further down. And that is the position and the intensity of the dot. Gray, black, bright white, all tell you different stories. Now, some of the terminology we use is called amplification. These assist about what we see and how we interpret uh, the dots. Amplifications are processes by which the returning echoes are enhanced for us to interpret more easier. So the three types of amplification: the linear, logarithmic, and the S-curve. The linear is where it's somewhere, let's say it's an into 2 or an into 3, and the whole thing is into 2 or into 3. So it's a more simpler way of amplification. But the difference is that you cannot have a large range because you're amplifying. If you have a 50 and you multiply it by 3, you get a 150. It could be outside the range of interpretation. And that is why you have a logarithmic scale. In the lower parts, the multiplication factor is less. And as it goes higher, it changes so that the whole range of the amplitudes can be seen by using a logarithmic scale. And then you have the S-curves. The S-curves is when you combine different linear and logarithmic scales, like at different intensities. If you want to pick out really low intensities and you want to pick out and you want to bring high intensities inside the curve, you have an S-shaped curve, which has the nature of amplification is different at different parts. Gain is when you increase or decrease the amplitude uh, to interpret it better on your monitor. So gain is not an amplification. It's just a method by which if you want to differentiate a light gray from a light gray from a white, and everything looks white. When you reduce the gain, you can see the difference in the dots, and that helps you interpret tissue densities differently. And a time gain compensation is where that, as I said, each dot is time. The position of the dot is a reflecting, the position depends on the time it gets reflected back. So by time gain compensation, you can say that, okay, I want to enhance the mid-vitreous cavity, and all the other signals are kind of reduced, and you increase only a part of the B scan. Just remember, the whole eye is only about what you're scanning is about 4 cm. So you can find smaller segments to do. I'm not going to this now. These are all the indications. If you want to take a snapshot of this, it's fine. We'll all discuss this later. So examination technique, these are some of the basics. Most of the time the patient is reclining. Sometimes you make the patient sit up for certain particular things, like we'll just mention it, like assessing shifting fluid. If you want to displace an air bubble which is in the center of your view, and when you're lying up, it comes and sits underneath the cornea and affects you, you can make the patient sit up. Every probe has got a marker. So what is a marker useful for? The marker tells you uh, from where to where you scan. You see the curve on the curve of the eye. The marker is always at top of the curve. So if this was a marker and you place it on the globe, the marker position would be, the curve would start from here, and this would be the top of the marker. By convention, you keep the marker nasally or superiorly for all scans, just to indicate that this is so if somebody doesn't mention that it's a longitudinal scan or a transverse scan, the convention would let you say, but properly the person doing it also should follow the convention, and the person interpreting the scan should believe the person doing the scan has done the convention. So it's always better to mention your scan protocol as to where the marker, where what type of scan is, and that gets away with a lot of confusion between the two parties interpreting it. So let's go to the basic types of scan. You have something called an axial scan. The nature of the word is axial. It goes to the center. You have an axial horizontal and an axial vertical. You have a transverse scan, where the probe marker is parallel to the limbus, and a longitudinal scan where the probe marker is perpendicular to the limbus. Now, all this is just talking now. Let's get to what these things are. So this is another thing. When you look at the picture on the right, you see how a transverse scan is placed. The marker, or which shows the cut section of the B scan, how it is placed. In the transverse scan, everything is parallel to the limbus, while in the longitudinal scan, everything is pointing towards the limbus. Okay. And on the extreme right, you see the axial scan, where you see it is placed dead center, a horizontal scan or a vertical scan. And why do you have these different scans? See, this is the first concept we need to bring in, is how and why we are doing different things. When you do what do you say, a B scan first, the first thing you want to know is a posterior pole, and that is why you do a screening with an axial scan. Or you can do it in the posterior pole with an axial scan and the periphery with a transverse scan. That's your screening tool. So what does the axial scan do? We'll come to that. And then you have your diagnosing. Again, the axial and the transverse scans are for diagnosis. But when you go to characterizing the lesion, that is when the longitudinal scans come out. So this is a rough idea about why you're choosing different scans. And let's go to the axial scan first. I personally prefer not to scan on an open globe. I like to do it through the lids, but this image shows you can anesthetize the eye and do it. It should be sufficient to actually do it on a closed lid in all times. So your axial scan is AH or AV, that is axial horizontal or axial vertical, and the picture, it shows the cut section. Let's go to this picture. So an axial horizontal scan is placed on the center of the cornea. The marker is towards the nasal side by convention, and then you get a cut section that includes the macula and the optic nerve. So this is how it is. You have the optic nerve, and then if the scan is placed on the temporal side, you have the macula above the optic nerve shadow, and if the scan is placed on the nasal side, you have it below. So this is how you know. And then you have an axial vertical. An axial vertical scan, typically you are looking for the optic nerve shadow. When you place the probe marker is placed superiorly, and you identify the optic nerve shadow. So please look at this. You have the optic nerve shadow. You are not supposed to comment about the macula in an axial vertical scan because you're missing the macula. But there is a technique by which you can sweep through. And this is the technique. It is close by, and then when you go through and you hit the optic nerve shadow, you sweep it temporarily, and then you can see what is happening on the papillomacular bundle, and then you'll reach the fovea. So you sweep the angle of the axial scan slightly, and that is how you identify. And then you have to go back to the optic nerve shadow to know the relationship between the macula, the presumed macula, and the optic nerve shadow. So that's how you sweep across the papillomacular bundle, by changing the angulation of the probe. A transverse scan is when, as I said, the probe is parallel to the limbus. And you can imagine that you're getting a cut section because of that. You're panning the retina. And and you look at about 4 to 6 clock hours at the same time. So how do you designate a transverse scan? You call it T12. If the position is at 12 o'clock and you're scanning the inferior retina, you call it T3, depending on the eye, whether you're the nasal or the temporal retina, T6, nasal or temporal retina, and T9, when you keep it down, you're scanning up and you're scanning the superior retina. That's the terminology: T12, T3, T6, and T9. And this is what a transverse can do. It's like painting a wall. Just imagine you're painting a wall. This is what a transverse scan does. You take the scan across, and this is a small animation, and you'll see that this is how, if there's a lesion, this is what you would do. You would paint it across. And that is why I said this is a transverse scan is often a screening tool. You're screening for lesions, larger lesions, which are not in the posterior pole, in the mid periphery and the periphery. You're screening for them. And for that, you understand you've got to tilt your probe up and down, and your sound goes and it kind of paints the wall. Okay, so that is what you're doing with a transverse scan. Now you're doing a longitudinal scan. A longitudinal scan is when the probe is perpendicular to the limbus. And so you can always imagine that what happens, you're scanning from the periphery to the posterior pole. Okay, you're scanning from the periphery to the posterior pole in each clock hour. So when do you do this? After you have found a lesion by a scan or a screening technique, like a transverse scan, then you want to know the nature of the lesion. And that is why you do this. And this is what you do. Okay, so you can see your scan is not going above and down. You're not moving it. It's like a yardstick. You just put it and you're just kind of feeling how far that lesion is from the periphery. You scan to the optic nerve. So the optic nerve is always in the inferior part of the scan. And then by virtue of this, what do? You get, see that. You can measure the distance from the lesion to the optic disc shadow. You can get the basal diameter of the lesion, and you can even find the distance from the lesion to the periphery, though it might not be that accurate, but at least on the scan. So this is why you start characterizing a lesion by using a longitudinal scan. Okay, so the transverse scan is like painting up and down a wall, where you go across and try to find it. The longitudinal scan is like, from you want to find the distance to an object. You take a stick and you try to measure the distance from you and the object, and the characterization. So the special techniques include a topographic scan, a quantitative scans, and kinetic echography. We'll just go through this. The quantitative scan is when you're looking at the scan and you're looking at the reflectivity from the surface. You're looking at the internal structure, whether it's all regular inside or it's a variable structure inside. And you're looking, if it's a regular structure, if it's homogeneous, you're looking whether the sound waves are attenuating. What do you mean by attenuating? When sound goes through an internal structure, you can always think of there's impedance and there's an amount of reflectivity. But the sound is slowed down. It is the beam is attenuated, it's absorbed, and therefore the strength of the beam reduces. And that is called, you'll have a decline in the spike height because of that. We'll see it in a couple of lesions down. So kinetic evaluation is when you or the probe moves. See, when you can move your probe and you can get a rough idea about the mobility of things. But sometimes you keep the probe steady and you ask the patient to move the eye, and all these free moving dots, which they can represent, let's say, I'm going to use terminology now, vitreous hemorrhage, or they can represent a retinal detachment, or they can represent membranes. they may keep on moving after the movement of the eye stops. That's like inertia and momentum kind of thing. So if after you ask the patient to move the eye and then you ask them to stop and the structures keep on moving, that is a technique of assessment called assessing after movements. That is, after the couple of seconds after the movement stops, you're still looking at how the echoes behave inside. Okay. Um, and then there's a spontaneous movement. When you have highly vascular tumors, you can imagine the only thing moving inside the vascular tumor is a vasculature. What do you say? Blood vessels pumping. And sometimes you can see that on inside the vascularity of a tumor, you can see the blood vessels moving. And if you're a very good ultrasonographer, you can see the vertical A-scan height spikes going up and down if you have that much patience. And there's another kind of movement called convection movement. So when you have things moving inside the eye by itself. So basically, this is not when you see a vitreous hemorrhage moving. That is not the typical terminology. When you have cholesterol or calcium inside long-standing retinal detachments or long-standing vitreous hemorrhages you have, and they just keep on moving by convection currents, and that is called the convection mobility. And like any lesion anywhere in the body, your ultrasound helps you to find the location, the extent, the dimensions. But what it does additional is it tells you the interior and the surface. What is the reflectivity from the surface? What is the nature of the interior? Is it homogeneous, heterogeneous? It is hyper, is it hypoechoic? Does it have areas of very high echogenicity like calcium? All these things are brought out in a description of a lesion, but the essential nature is the same. That is what I said, the internal reflectivity, the sound attenuation, like we meant, solid tubers impede or slow down sound, and the mobility, like we said. So now let's go to the principle of diagnosis. Like most retinal diagnostic methodology, pattern recognition, when you see something in the first 1 or 2 seconds, the diagnosis comes to your mind, which is extremely good, but it can be misleading. So one of the biggest dangers of pattern recognition is that you can be climbing the wrong tree from the beginning itself. Okay. The second point is understanding signs. Please understand that there are a lot of named signs, quoted signs, a lot of signs that you think everything can be variable. So you cannot say retinal detachments are always 100% are what do you say reflective like the sclera. You cannot say that. There are a lot of variations. So we'll just deal with some of those things as we go by, but please try to understand that uh, recognizing a pattern, confirming the pattern, understanding that things can be variable are the first couple of things we need to know. And next is use of strong, accurate terminology while reporting. I'll give you an example. When moderate reflective echoes in the vitreous cavity with after movements and attachment to the disc, diagnostic of vitreous hemorrhage. Seemingly, it is something that all of us would report without a thought in their minds, but I can identify 5 problems in this. Okay, the 5 problems. If you can have a minute to think in your mind what the 5 problems is, and I'll just click the next and we'll go to what the 5 problems are. Okay. Yeah, time up. So the number of the echoes. Moderate is defining the number of the echoes. So there is a difference between moderate and medium. When you define reflectivity, it is low, medium, and high. Moderate does not define reflectivity. Moderate is a terminology for number of echoes. So few, moderate, and plentiful could be a good terminology for the number. Here, the type of echoes, whether it is dot or clump, is not mentioned. In this particular thing, the nature of the membrane echo is not mentioned. And off the top, there is no it characteristically says it's diagnostic of vitreous hemorrhage, where you cannot make a diagnosis based on the dots or that it is a vitreous hemorrhage. It could be a vitritis, it could be calcium, it could be amyloidosis, it could be anything you know. So, and the retinal status is not mentioned here. So a seemingly good report has 5 um, significant, I would say, mishaps. So let's go to a few things, clinical scenarios. So vitreous detachment, the first thing you learn is how to diagnose a vitreous detachment, and you get shouted if you make a mistake between retinal detachment and vitreous detachment. So there are a few things. One, just imagine what it is before you diagnose. It's a thin vitreous membrane, okay? And where is the vitreous membrane? It can be attached to the disc. It may not be attached to the disc. So that is one point, okay? But the attachment to the disc can be broad, it can be pinpoint also. You can imagine that when the vitreous is kind of detained, you can have a very focal attachment. Reflectivity is usually low. Bloodline PVD is moderate to high. So what does that mean basically? It means that your typical description of having a thin vitreous membrane can be altered. So I said signs can change. So this is an example. If you have a thick blood layered PVD, this is what we call, or if you have an inflammatory membrane layering PVD, or lots of causes, the posterior vitreous phase can be thicker than normal. But one good point to note is that uniformity. Retinal detachment membranes are generally uniform, but as you see in this picture, you have a variability. Some part is not uniform, some part is uniform, and that's a very good pointer. The second good pointer is that how it is attached to the disc. You know that the retinal detachment can only be attached to the two edges of the disc, but a vitreous detachment can have a very focal point of attachment also, and it has good after movements generally, okay? A retinal detachment, let's go away. It's a broader attachment to a disc. Okay, it is always attached to the optic. That's common sense. The retinal detachments are always attached to the optic disc, unless it's a traumatic where you have a total avulsion or a total. Still, it's not possible. It's attached to the disc. The reflectivity is 100%. I put it in red because no, a long-standing RD, which gets thinner and thinner and thinner, it may change. Restricted after movements, yes, but in a very fresh RD, something like a GRT, you can have tremendous after movements also. So these are the points by which we try to diagnose, but these are not absolute all the time. Okay. And there are other changes in RD, like you see anterior PVR changes here, which causes a funnel, and all these changes here. You can have cysts also. An exudative RD is something that moves. So the terminology that you use for exudative RD is demonstrating shifting fluid. So what is shifting fluid? Because the fluid is mobile, when you make the patient sit, the fluid goes down. And so what happens on an ultrasound? The macula flattens. So you have to make the patient lie down, take a picture of the macula, the scan of the macula. You'll see how bullet is it. Make the patient sit down, the macula flattens, and the inferior retina balloons up. So that is shifting fluid. Why is it in red? Caution. A fresh rhegmatogenous retinal detachment can shift in the margin of in the border of the retinal detachment. That is, the fluid can go inferiorly and simulate a exudative retinal detachment also. So yes, most of the time you'll get it right, but always keep this small point in mind. Attractional retinal detachments are a totally different ball game. The nature of the RD is different. It's more you'll have concave appearances because between the points of attachment, and the history and the nature of the disease is also different in most times. Choroidal detachments do not reach the optic nerve. I mean, the choroidal detachment, the borders, they can be extremely big, obscuring the attachment, and you making you doubt whether there's an attachment to the obscuring. But why this happens is that it is limited by the vortex vein exit. So the choroidal detachment technically cannot go beyond that point. But there is something that is very important, and it's more like a knowing what it is, that is looking at that particular sign. So this is called the M sign. That is, you have two peaks. So one peak is because of the retinal detachment, and the second peak is because of the choroidal. The first peak is not the retina, and the second peak is because of the choroid, and is more prominent than usual, and that is why you get an M peak. So there are different ways to mention. Here I'm going to talk about degenerative retinoschisis. Degenerative retinoschisis, the membrane is very thin, it hardly moves, and it is like in the periphery, and you can get it confused, not so much with the choroidal detachment, but it doesn't come to the posterior pole unless there is a coexisting retinal detachment along with it. So that's one thing we can make out here. And this is a nice thing that we all talked about, the attachment to the disc. It may or may not be attached to the disc, the vitreous. the shape is usually a very fine membrane versus a very thick membrane. 100% compared to the choroidal sclera, less than 100%. There are differences. When you reduce the gain, the vitreous detachment disappears because it's a thinner tissue. After movements are good versus limited. There are ways. There are circumstances where this may not be sometimes exactly true, but it's a good thing. And you can have other features like PVR membranes and CDs associated with RD. In viscous detachment, you may have hemorrhages, and depending on neovascularization and the thickness may be variable. So vitreous hemorrhages, this is what we like to describe like dots and clumps. Okay, membranes are also a part of it, but dots and clumps, that's the terminology. Dot is independent, clumps are when all of them are together. So the nature of the vitreous hemorrhage, it can be intragel, it can be subhyaloid, prehyaloid, and all of this have got subtle variations. So it can be a pure vitreous hemorrhage, or it can be a vitreous hemorrhage associated with a diabetic tractional retinal detachment and many other reasons. Asteroid hyalosis is whether you have highly reflective mobile clumps. So you can have a lot of other conditions which mimic this, but there is one very characteristic feature. It's called the lucid zone. There's always, in a asteroid hyalosis, there's always a zone that is between the echoes and the retina called the lucid zone. And as we are surgeons, sometimes we struggle with its normal vitreous attached over there, which doesn't have these calcium echoes inside. It's very hard to induce a posterior vitreous detachment when you have an asteroid hyalosis, and that is the reason why you have an intact, thick cortical vitreous around the echoes. What does silicone oil do? Okay, this is what everybody knows, but why silicone oil causes apparent lengthening? The speed is different. The speed is retarded. Echoes come slower. The machine doesn't know that the echoes are slower. It just interprets it unless you change the setting, and therefore it gives you the impression that the globe is larger. The globe isn't larger. The speed of the sound is reduced. Echoes come slower. Machine interprets that the axial length is more. Acoustic reverberations. It's a very important thing to know. Acoustic reverberations are these small lines that you see at regular intervals that happen, and they happen when you have two smooth surfaces. That is, there's a reflection from the front, light goes in, reflects from the back surface of that smooth surface. Let me reveal the thing. It's an IOL or a piece of glass or a glass foreign body where reflection happens from the both surfaces. So each time it gets reflected, part of it is transmitted back to the transducer, and some goes back inside, and then it is reflected again. Some goes out, some goes back inside, and this reflective process is kind of perpetuates for some time. And that is why you have these regular things. So whenever you see it, you just imagine two things theoretically: regular surface parallel to each other, reflective. So IOL and glass would be the two most common things, but the theory behind it should be known so that you can make a diagnosis. Now, again, tumors, we talk quantitative. We look at the shape, size, surface, reflectivity, the acoustic impedance, the acoustic shadowing, the vascularity, and all those things. We'll go to this. So this is the most important thing. You have a retinoblastoma, and the diagnostic thing in a retinoblastoma is intralesional calcium. So you see these hyperreflective dots. The minute you see it, what is the first thing you do? Reduce the gain. The tumor disappears, the calcium remains, and that is how you make a diagnosis of calcium inside the ocular structures. If it is inside the mass, that is one of the diagnostic features of retinoblastoma as compared to a Coats disease, where the calcium can be underneath the retina in the chronic subretinal fluid also. Okay. So the next would be a choroidal melanoma. We'll come into more details with this. I'm just going to skip through some of the features. A choroidal melanoma has got a dome-shaped lesion. You see it's very uniform inside. It produces what we talk acoustic impedance. That is because it is impeding the signal, the signal gets lower and lower, and this is called what do you say, acoustic shadowing or acoustic impedance or things. Endophthalmitis is when you see a lot of presence of echoes inside the vitreous cavity. You can have dots, you can have clumps, you can have membrane echoes. And here is one feature where the knowing the history is important. Okay, so along with this, you will be looking at other signs as to whether a retinal detachment or a choroidal detachment, or whether you have a scleral edema coming, whether it is an endophthalmitis is going to a panophthalmitis. So, presence of an intraocular foreign body. This is not only a foreign body. Any substance in the eye, if it is strong enough, you can imagine all the sound waves hit the surface and go back. Nothing is transmitted, and therefore you have this particular black thing behind it. That's a shadow. It's called acoustic shadowing. Okay, so acoustic shadowing is when the material is so dense, calcium, metal, stone, anything that is so dense that it doesn't let the perpetration of the sound waves. Again, optic disc is another thing that produces something like acoustic shadowing. It is sitting on top of the optic nerve head, and what do you say? It doesn't produce any widening of the optic nerve shadow. That happens in other conditions. It can happen in other conditions, but in this particular condition, it is not seen. Now let's do a little bit of orbital scans over. You have a transocular scan and a paraocular scan. We generally do transocular scan. So let's to know that what is about an orbital scans. Why is the orbital scans intense and uniform? Why? Anomalies are generally hyperreflective. Why? And hyperreflective structures you have to know. So just look at this picture. I've covered half of it. So you see everything here is intensely white. So why does that? So has anybody thought about why it happens? And now a lesion is hyporeflective. So let's look into what happens here. It is because of the orbital fat. And because of the orbital fat, all of this is hyperechoic or reflective. And why does that happen? It's a very simple explanation. You have multiple interfaces. When you have an interface, all these interfaces are reflecting back the sound waves, and each produces a small white dot. And the white dot produces a uniform, intensive, hyperechoic background. That's a word, background. And when you have any changes like a tumor or or fibrosis, what happens? It becomes uniform. The interface is lost. And when it becomes uniform, we've learned sound is impeded. So you don't have that high reflective things coming back. It is darker. Therefore, you have this particular image where you see the fat produces hyper echoic, intense white signals, and anything that is solid produces darker because it is impeded. Okay. These are some of the examples when you see this is a tumor, which is not a tumor. I don't know that. This is a lesion which is impinging on the optic nerve head. This is another lesion where you can see the hypoechoic nature of it. The next is the extraocular muscle scans, where you can do longitudinal scans along the muscle to get the muscle appearance, or you can just cut across it to get an oval appearance. And this is how a muscle would appear like. It's hypo amongst the orbital fat, and this is the spindle-like appearance. And this is the oval kind of appearance when you cut across a muscle. And this is when the muscle gets thickened. Okay, so in a patient with thyroid eye disease, this is a very nice image of a belly thickening with a tendon sparing, and this is a cross section which shows the thickened muscle. Again, this is another patient where you see both the muscle and the tendon are thickened. So this is a myositis. It's not a thyroid eye disease. It's a more diffuse disease. And this is when you have a pseudo tumor like lesion or an inflammatory disease inside the muscle cone alongside the optic nerve. Okay, so let's go to clinical scenarios. I'll just run through this fast because these are some of the learning points are here and the discussion points. Dense cataract, retina not visualized. This is when you get an BSCAN ordered sometimes. So these are the things you can see sometimes, not always, but this is a pre-retinal hemorrhage. This is a more, what do you say, subhyaloid hemorrhage with a slight elevation here. And this is the worrying part of this. This could be corresponding to a choroidal neovascular membrane. This is sometimes you discover RDs and inside when you have no view. So this is something that sometimes it catches you unaware. You see the cavity is empty, you say the patient all okay, but when you trace the RCS complex, you see a small thickening over here. And sometimes if this macular scar is big enough, you can pick out a CNVM sometimes. So another thing, if you can quickly look at these pictures, this is not something to be quoted very, very often, but you can see a small dimple at the optic nerve head. In a significant cupping, you can identify it on an ultrasound. Not always. Very dangerous thing sometimes to tell the patient that you have cupping or you don't have cupping based on the ultrasound. But for you as a clinician, sometimes it gives you invaluable uh, impressions of how to deal with the patient and give a guarded prognosis before cataract surgery. A vitreous hemorrhage in a known diabetic, you can see this is a subhyaloid hemorrhage. You see the hyaloid margin with small dots underneath it. This is a point against a fresh RD. If you see echoes underneath a membrane, the chance of it being an RD are less. So let's go to a video here. You can see a subhyaloid hemorrhage. And that is a mobile hemorrhage. It's an intragel hemorrhage, which is quite mobile, and the subhyaloid space is relatively free. So these are two contrasting pictures. And that is what we mean by after movements. You can see after the image stops, you can see it still moves for some more time. Sometimes with vitreous hemorrhages, you also pick up tractional retinal detachments. With this is the hyaloid attached to it. This is the tenting. Sometimes the tenting is so significant you have a flat top or a tabletop-like appearance. So this is a diabetic tractional retinal detachment with a vitreous hemorrhage. Sometimes you got vitreous hemorrhages, not a known diabetic. Here you see the view is very poor. You do an ultrasound and you see fine small dots with currently without a diagnosis at this point of time. Sometimes it's very obvious when you see large, thick intragel hemorrhages and you see thickening of the retinocoroidal complex, you have something, you have warning bells in your mind. And sometimes it's quite obvious. These are cases of PCV, polypoidal choroidal, where you see an elevation with something, the intragel hemorrhage is in contact with it. So this is an example of a breakthrough bleed that you see sometimes when you send a patient for BSCAN. These are more severe bleeds where the entire choroidal complex is thickened and you have very thick intragel hemorrhage. You can, when you do a mobility, you'll see the mobility is quite less because the whole gel is filled with echoes. Sometimes you get pictures like this, which are very confusing. This is a hyperreflectivity you see here. Scars can produce this sometimes. Sometimes dystrophic calcification can produce images like this. Sometimes this could be representative of an old inflammatory scar also. Let's look at lesions, okay? So like we said, this lesion, we discussed it before, retinoblastoma with intra-lesional calcification. Something else, you have a cholesterol appearance, very dense appearance inside here. The base and the height are measured. This is an example of a melanoma. And this is a more example where you see the decremental echoes over here, solid lesion inside, that a typical appearance. The distinction between the choroidal and the RC, the retinal choroidal distinctness is gone. That is called choroidal excavation, usually at the edges of the tumor because of the ultrasonographic properties. This is a textbook image which shows a lot of typical things: a retinal detachment, high reflectivity on the surface, low reflectivity inside, choroidal excavation. It was a very typical image with the decremental echoes you see of the internal acoustic impedance. Another, the cholesterol appearance with a slight breakthrough like of appearance where you can see it just kind of going above it like over there. Okay. A hemangioma is slightly different with the echoes. This is a very small hemangioma, but there's no, it's more highly reflective than a melanoma. Choroidal osteoma will give you it's this kind of appearance, but this is very characteristic. It's a large area. That's how you differentiate it from a truce. It's a larger, flatter area of calcification. Like I said, anything that is very stiff and thick will produce acoustic back shadowing. So that's how you identify calcium. Another lesion where you see very thickened appearance on the BSCAN, it's a lumpy, bumpy choroid, and this is an example of metastasis. Retinal detachment pre-surgical, you're looking at, again, the PVD attachment here. You're seeing, what do you say? Sorry, that just gone. This is a retinal detachment attached to the edge of the optic nerve head. You can see the restricted mobility over here. And that is why after the movement, it just gives a few flutters here and there, and that's it. So again, you see the retinal detachment with limited restricted mobility, and that's how you diagnose a retinal detachment. There's a vitreous movement. You can see it above it. So a choroidal detachment, the disc, it is not attached to the edge of the disc. A retinal detachment is attached, but it's a fine, and that's a CPVD on the other side, which is not exactly a diagnostic challenge. So you can see when a large tear happens, sometimes on ultrasound, you can see a gap and you can see the break over there. Here you can see just diagnosing a general retinal detachment, but this is very interesting. This is a GRT, okay? And of all the theory you've learned, you can see that the attachment of the GRT here, the vitreous is attached to the anterior leaflet and the posterior leaflet. You don't need a BSCAN to diagnose a GRT, but this was very interesting to know that the vitreous is attached to the anterior leaflet. Another features, you have a PVR, you have an open funnel RD with anterior changes over here happening. And this is when you hardly realize what is happening. It's a open funnel RD. The cross section doesn't. It's a closed funnel RD, but the cross section doesn't exactly show that. It's through the contracted retina. This is how a choroidal detachment, we've gone through it. You can see this is a very interesting thing. You see the choroid RCS complex is thickened and then it divides into two like this. So that is the sclera still here and the retina choroid goes up there. TRDs, you look at the attachment, tractional retinal detachment. This is a focal pinpoint TRD over there. And then this is a tabletop. You're looking at pre-surgical. You decide where you want to start your surgery, how you're going to peel it off, and all those things. So this is an example where you can see multiple attachments. Okay. Scenario 7 is unexplained visual loss. Sometimes you just do this, you have no features, but here, when you look carefully, you can see a subtle T sign and a thickened RCS complex. So this was a posterior scleritis. Here you see a hyperreflective body on top of the optic nerve. This was not drusen. This was a calcified abscess sitting on the optic nerve head. The scenario 8 is when you have a phthisis. Why do you want to do an ultrasound in a case of phthisis? You're looking for a mass lesion. You're looking for calcification. Why? We'll tell you later. You're looking at the change in axial length and certain other conditions like microphthalmos and ophthalmos. So this is a disorganized globe. You have a lot of stuff inside. You don't see the RCS complex properly. Everything is here and there. You've taken the measurement. You have it 18.76. Okay. So always do the measurement of the other eye. This is a different patient, but you do the patient of the other eye and you check the axial length, and the difference should be at least 3 millimeters for you to say it's different. So this is another patient which had a chronic retinal detachment. The axial length is reduced, and this is a pre-phthysical eye. But here also you see some changes that are happening with hyperreflectivity, and you've got to watch it whether it is coat calcification, ocular coat calcification happening. Again, please note this is not the exact way to do an axial length measurement. You have to get the disc and the macula, and the measurement is not to the optic disc. The measurement is to the macula. So this is how you take an axial length measurement, an axial horizontal scan, see the optic nerve head, identify the macula, and from the first echo, the first hyper echo to the macula would be how you consistently do axial. I think, and this is the reason why this is a patient with papilledema. The disc is elevated, so you wouldn't get a proper axial length measurement. So dots can be by endophthalmitis, asteroid, vitreous, lymphoma, intermediate uveitis, and sometimes you see things like this. You think it is innocuous. Sometimes you see things like this. This is an example of emulsified silicone oil, which gives you multiple echoes, but it's actually innocuous. Sometimes when you see a lot of dots, you don't do anything about it. Months later, it comes to you like this with bad inflammatory membranes. So always be very wary when you see dots. They can be simple. And one dictum I'm going to tell you is that sometimes you see things like this. You think there's nothing. Not seeing dots is also difficult. Sometimes it's so suppose you have a very virulent endophthalmitis. Sometimes it appears like this because the chamber is so full of echoes that you don't see anything differentiated. It's a very rare scenario, but it can happen also. So BSCAN is about skill and patience, and getting skill is about patience. So I said BSCAN is about patience and patience. You have to do it meticulously, and you have to look for what you find. Cursory BSCANs are your greatest enemy. You see something, you don't look at something else, you miss a whole lot of things. When you do a BSCAN, it will not tell you your the diagnosis. It will not come written there, RD, but it will also not tell you what isn't there. Everything that is there is demonstrated on the display. So you have to use imaging, understanding, not imagination. And you have to deduce from the facts and you should not deduct from the information. Okay, so happy scanning. Thank you so much.
Thank you, Dr. Nair, for that wonderfully insightful and practical talk that you gave, and you illustrated it with real life examples. So, thank you so much.
Thank
I'm
you.
sure all the people who are there with us this evening are going to approach their next BSCAN with a lot more confidence and also a lot more curiosity. So, with that, we move on to our panelists. So, first of all, Dr. Munish Saxena,
Yeah,
anything
hi.
that you'd like to add onto this? Any insights
Uh,
or any perspectives on BSCAN?
Excellent presentation, sir. That was very enlightening. We get more of a mature cataract patients, especially in young trauma patients. The B scan is more useful, also useful in detecting posterior capsule of the cataract. Is there a rupture or posterior capsule rupture or not? So that is more helpful in our cases.
Yeah,
True.
absolutely. So, I mean, that is I mean, how when we learned our B scan, it was always the first line was always PC intact or PC
Yeah.
ruptured, and
Thank you so much.
looking for echoes just behind the posterior capsule is one of the most important things to diagnose whether there's a PC rupture.
Dr. Kharesa, anything that you would like to add on to this? Uh, Dr.
We'll
Khare,
just
I think,
emphasize. Hello.
yes.
Yeah. Many a times we see cases coming to us. Patients, anterior segment surgeons have operated cases where they've not evaluated the globe just because they could not see anything inside. They operate and then decide on what's to be done for the posterior segment. I think B scan is very, very important in preoperative evaluation, and it's better to know the morphology of the back part of the eye before we do anything in any eye. If we are not able to see the posterior segment, or suppose there is a opaque cornea, opaque cataract, whatever it is, but it's important that we do a complete assessment before we tackle those eyes.
Yeah,
True.
I'd like to just add a point here. So all the junior people, when they come out, they start their practices, they're all looking at what equipment to buy, and they're also looking at what equipment to cut. So that is a big point here. So some of the things that get cut first is is the B scan because it is not glamorous. But trust me, if you're a cataract surgeon, if you're a VR surgeon, this is your safety line sometimes. Okay, sometimes you can manage without a wide field OCT or a wide field imaging unit, but your basic B scan, you should not get into trouble after doing a cataract surgery or an unplanned you'd go in for a vitrectomy VR without a B scan. See, it's not that you have to buy it, but you have to have access to it and you have to have the habit of prescribing ultrasonography. So it's an important, I think it's a very important point Dr. Bhushan made, and when the importance is has to be underlined. Yeah.
True. Thank you, Dr. Bhushan. Dr. Abhijat, anything that you would like to comment on?
Yeah. So it was a very insightful presentation by sir, and I totally agree. So when I entered my practice, which was like 3 to 4 years back, the first thing that I did was I started looking for an access to BSCAN. I didn't purchase it, but yeah, and also I totally agree with sir that you need to know the basics of the scan. If you know the exact technique and you start visualizing it in a three-dimensional form, you will always be able to localize all the lesions, even small tears that you cannot see because of the mature cataract or because of less visibility due to vitreous hemorrhage or something like that. Even for the tumors, you can exactly localize where the tumor is, how large the tumor is, and then you can, just treat uh, according to that. So yeah, start having a basic three-dimensional imaging in your mind. Always remember the basics, and do remember B scans are something very wonderful. They are kind of an underdog of retinal diagnostics, and I feel we should do more and more B scans very regularly.
Yeah,
Absolutely,
true.
brilliant point over there. Yeah.
So, one thing that I always tell my postgraduates, to build up their three-dimensional thinking is to do B scans in patients with clear media. So they can actually visualize the lesion, see the location of the lesion, and then, see inside and then do the B scan. So before they do start doing it in opaque media. So,
So, I mean, like I said before, that's a brilliant point. Like I said before, the biggest enemy of the B scan is your time. You have to spend time on it. You
right.
put the scan 1 minute later, you make a diagnosis of PVD. You don't look at the periphery. You don't look how it's acting, and then you go off, write it on a piece of paper. And like everything in ophthalmology, the minute you commit it to paper, it's committed. So just remember that before you commit to paper, you've got to have a great idea in your mind, a three-dimensional idea, reach a proper diagnosis. If you have any apprehensions regarding whether you're right or wrong in it, you just mention that also. And please remember, it's not a one-time thing. You can do serial. If you have a doubt, you can do serial ultrasonography. Call the patient after 3 or 4 days. See the nature of the echoes changing, and endophthalmitis will change. And RD, if you have a doubt between a PVD and RD, 3 days later, you may call the patient back and see if anything has changed. So, a serial ultrasonography is a brilliant thing to do also.
Mhm. Dr. Bhushan, what would you say are some of the common mistakes that you see your postgraduates making, or
Uh,
while doing
many,
or interpreting?
many a times, a patient comes to us with just a printout of a sonography.
True.
There is no report associated with it. And just seeing a membrane configuration or lot of dots, they try to interpret that without having a firm report in hand. I think what Dr. Unni mentioned right in the beginning is how comprehensive a report should be. And only after that do we know the basically dynamic nature of the lesion inside. Just a line configuration, a membrane configuration doesn't help us understand the lesion. So that is something very important before we counsel a patient. If need be, we repeat the ultrasound, get a good report, and then only interpret it. Just a paper printout doesn't matter for us.
So I think
Very
Dr. Bhushan has given a very important philosophical life lesson also. That is, life is not an OSCE.
true,
So you need to see the entire thing and just not one picture before you make a diagnosis.
true. And it has to be a dynamic examination. Just seeing
Absolutely.
a 2D picture, it just doesn't give us the information. So we have a question in our chat box. How to differentiate between vitritis and vitreous hemorrhage? I think that is one of the common scenarios that postgraduates face. Dr. Uni, would you like to take that?
You should not differentiate it based, and you should not commit it unless you know the whole history. If you want to make some sort of differentiation, see, basically your clinical history is in front of you. It's not going to be a patient off the street and you're going to say, is it vitritis and vitreous hemorrhage? You have an entire clinical history in front of you. Uh, if if there are any things, I would say, if you see a retinal detachment, it's likely to be a vitreous hemorrhage. If you see a lot of crisscross membranes inside going across, which is not a diabetic TRD configuration, it could be an inflammatory disease. But I mean, my talk was entirely about not committing. BSCAN is a corroborative device. It doesn't label it as vitritis or vitreous hemorrhage. It's a corroborative device. You look at patterns. Just by looking at the echoes, you cannot say if it's vitritis or vitreous hemorrhage, but you've got to look of the coexisting things. If you see a large abscess with a bit of calcification, okay, vitritis. If you see a TRD, vitreous hemorrhage. If you see an RD, vitreous hemorrhage. If you see a PCV configuration, vitreous hemorrhage. If you see, if the history is post-surgical, endophthalmitis vitritis. So there are, if you see a very thickened RCS complex with the T sign, vitritis. So it's a constellation of features. Don't look at one, and that's the worst thing you can do to yourself. That is diagnose a vitritis or vitreous hemorrhage based on one, the nature of the vitreous echoes.
Very true. Dr. Uni, do you think there is a role for AI in B-scan ultrasound, or is there at present, are there any systems or models which are using the AI to interpret B-scans that you're aware of? So there's a question there in our chat box.
Is it to me?
Yes.
Okay, so I mean, I know of a couple of people who are doing AI, but I mean, I'm not sure of the outcomes. I know a group that is looking at mass lesion identification and measurements using AI. So, but I don't know. Common diagnosis with AI, it certainly is possible. But I say, I mean, the variations, I mean, I don't think anything is impossible with AI nowadays. We have to have a basic differentiation. It should not be difficult. It should be
Right.
possible. But the postgraduates, you should be learning how to do B-scan, not looking at whether AI is coming or not.
Yeah.
Yeah.
Uh, so, Dr. Munish, again, the same question, and also Dr. Abhijat, any other tips, any common mistakes that you see postgraduates making, any tips that you would like to give them? Cases of trauma, how should they handle? So, how should they do a B scan in cases of trauma? Dr. Munish, would you like to
One,
take that?
yeah, one thing we should check both the eyes. Most of the people they do check the one eye, they don't compare it with the other eyes. That is most important, and they always do that in a hurry.
Very, very important point, especially where you have a doubt in cases of endophthalmitis, suppose whether there's an inflammation, those little dots, is that inflammatory? When you check with the other eye, so always compare with the other eye, and that gives you a little bit of a clue as to what's happening. Dr. Abhijat?
Yeah. So apart from this important thing that you need to check both the eyes, what commonly I feel that people are doing wrong is measuring the axial length wrong. That is again because of the fact they don't know from where to measure until where to measure and what kind of scan. So Nair sir actually told about this in his beginning part of the presentation, and I feel people should focus more on that also because you need to report the exact axial length of the eye. Again, here also, always compare the other eye axial length as well.
All right.
Okay, so I'd like to make a quick point about the trauma, which I think I haven't concentrated on much. So let's look at trauma. We just look at three things. First thing, when you report PC intactness in trauma. Second thing, echoes in the vitreous cavity. Three, whether tissues are pulled toward a particular area, which indicates incarceration, and the integrity, rupture globe incarceration. The next thing is any hyperreflective thing inside, which is beyond the vitreous hemorrhage echo, that is foreign body. The width of the optic nerve shadow, which could talk to you about avulsion. So in a systematic way, this could be the way you go through a trauma.
So another question that we have is that how does the B-scan ultrasound help us in managing a suprachoroidal hemorrhage? So, you look at liquefaction.
Yeah.
Yeah, Dr. Oni, you could take that.
So it usually comes when the scenarios when you get a intraoperative suprachoroidal hemorrhage is when you don't do an active management on table and then you wait and then you come out and you do a scan and you look at the echoes inside. And this is one of the most important things in which you do serial ultrasound. You're looking for the echogenicity to come down, have more hypoechoic areas inside, and that tells you that liquefaction has happened. Usually it's a 7 to 10 day process. Some of us give steroids just in case during the meantime. And when the echogenicity comes down in a suprachoroidal, that's when we take it for a secondary choroidal drainage.
True. Dr. Khare, anything that you'd like to add?
In relation to discussion on trauma, I will say that in ultrasound, we always depend on the difference between the acoustic impedance between two different objects. So if a foreign body is enmeshed in a clot of blood, if it's a thin foreign body, it can be missed. Secondly, it's also how the rays of sound basically hit on the foreign body. Suppose there is an eyelash which has gone inside, it can be missed if you basically, depending on the orientation of the foreign body inside the eye. And also, we should remember the resolution which we can pick up on ultrasound is also having some limitation. If it's if we are so sure that a foreign body may have entered with an entry wound, we may need to further evaluate these patients once the ocular integrity is restored, and we may need other imaging techniques and not rely only on a single report.
So I like to second that very vociferously. Important thing is your reporting. Do not write no IOFP. Please use the terminology no IOFP seen as of now. Make yourself safe. Always complement it with other imaging techniques, at least a CT scan if you're not sure what the type of IOFP is. But committing things like no IOFP, going inside later and finding something sitting there is going to be one of the biggest things. And you've already given a report saying no IOFP. So saving your reputation is equally important over there. As I said, the BSCAN is not it is not the thing that is going to screen the diagnosis at you. Sometimes the diagnosis is hidden amongst the echoes.
True. So, Dr. Abhijit, Dr. Manish, if there's anything else that you would like to add, otherwise we've come to the end of the session. Any
No,
parting
I
comments?
think it's pretty insightful, whatever sir has told, and just need to remember all these basic things, and we need to do it regularly. Just keep on practicing, and one day, one fine day, you'll get that confidence, and then you yourself will start doing these scans without anyone telling you to do it. So yeah, that's my take from this entire presentation.
Thank you. So, thank you so much, everyone. Thank you, Dr. Unikrishnan Nair, for that very, very insightful talk. You simplified everything so well, and I'm
Thank you.
sure the postgraduates will go back richer in their knowledge. A big thank you also to all our panelists, Dr. Bhushan Karesa, Dr. Abhijat Chaturvedi, Dr. Manish Saxena, for all their inputs and practical tips and pearls that they shared. So with that, we come to the end of this episode on BSCAN. I bid you all a very good night and request you all to join again next Thursday, where the ARC team will be back again with yet another episode of a PG teaching program. Thank you so much, everyone.
Thank you,
Thank you so much.
thank you
Thank
so
you.
much.
Thank you.
Thank
Thank you.
you.
Thank
See
you.
you. Bye bye.
Bye bye. Good night.